This is our Grand Rounds group presentation, and it includes Sydney Conley, Morgan Jokum, Victoria Miles, Jalea Moore, Marissa Morgan, and Maya Thomas.
The clinical data includes the following: background, chief complaint, presenting symptoms, and history. So for our Grand Rounds presentation, we had a 67-year-old African-American male with COPD. His chief complaint was shortness of breath. He also had symptoms of coughing and wheezing. We do know with COPD patients, they have frequent exacerbations, which lead to frequent hospitalizations. This patient was also hospitalized 3 weeks prior, and he has diabetes, hyperlipidemia, and depression. The depression is linked to him having to be in the hospital frequently, but also he only has one relative, his niece, whom he lives with, but she also does not call. He has no surgical history.
Next, we will be discussing the findings from the head-to-toe assessment that was performed the day of care. This is our head-to-toe assessment portion of our project, and I'll be discussing the results that we found on the day of care. Starting with his neuro, his pupils were reactive and accommodating. They were a size 2. And then our patient was also sedated, and his Glasgow Coma Scale was of 7. So he had, his eye opening was only to painful stimuli, same thing with his motor response, and then his verbal was non-responsive. When painful stimuli was applied, the patient somewhat opened his eyes and kind of moved his arms towards where we were giving that painful stimuli, but then he would go right back to resting pretty quickly after. Their skin was within normal limits. He had an elastic turgor. It was warm and dry. The only thing that was not within normal limits is he had 2 pressure wounds on his ischium. Our patient had a Braden scale of 12, and he lost points on this scale for being sedated, so he was completely immobile and relied on the nursing care. Because of this sedation, we were unable to assess his sensory perception and all of that fun stuff. For his nutrition, he lost points because he was on tube feeding, so he was getting adequate nutrition, but just was not able to sustain that nutrition on his own. Our patient had a Foley catheter in place, and it was a 16 French. That was in place a week prior to the day of care. His urine was clear and straw colored, and the amount was about 300 milliliters for the whole day, and that was just because his kidneys were not perfusing like they should have been. Upon assessment, our patient's vitals were a heart rate of 93, a blood pressure of 111/72, an O2 of 92, a respiratory rate of 30, and a temperature of 98.4. His respiratory rate was out of 30 just due to the ventilator settings being at a 30 as well. His respiratory findings included coarse lung sounds in the lower quadrants on both sides. His FiO2 settings were on 70%. Throughout the day, we had tried to lower his FiO2 level to 55%, but his O2 sats were not staying up to where we needed them to be for a COPD patient. The other settings for his ventilator were a PEEP of 12 and a respiratory rate of 30. The ventilator was also on a pressure control setting. Some more findings for his skin was he had no presenting edema. He had an elastic turgor, as I said earlier, and then he had moist mucous membranes. The gastrointestinal findings included a Dobhoff in place that was confirmed by an x-ray, active bowel sounds, and an abdomen that was soft and round. The day of care, he did not pass a bowel movement, but he had had one the day previous, and that was within normal limits. Our patient was in normal sinus rhythm and on continuous telemetry. They had flat neck veins and radial pulses that were strong and equal on both sides. He also had pedal pulses that were strong and equal on both sides. Their cap refill on all 4 extremities was less than 3 seconds. The IV access our patient had was a peripheral intravenous central catheter or a PICC line in his upper arm, and that was the only IV access that we had for him.
Next, we have our patient's diagnostic findings.
Here are our patient's lab values. The ones in red are the ones that were out of order. His BUN and his creatinine were out of range due to the lack of kidney perfusion. His glucose was too high due to the fact that he had diabetes and he was on tube feedings. His calcium and his phosphate are out of range due to the fact that he was immobile. So his body was pulling calcium from his bones to put in his blood, which brought his calcium up, and in turn brought his phosphate down since they have an inverse relationship. All the blood values are low because before labs were drawn, he had a massive epistaxis. And then here are his ABGs. His CO2 is too high due to the fact that he was on a vent, a chronic smoker, and the fact that he had COPD. So his ABGs showed that he was in compensated respiratory acidosis. He did have an x-ray to confirm Doppler placement, and all was good. And then we are pending results for a CT scan that was performed. The amount of O2 that our patient has been receiving and the extended time frame in which he's been receiving it has created a dependency on the oxygen that has not been able to be reversed. This is evidenced by the inability to wean him off the vent or lower his FiO2 settings and his ABGs. These are his latest ABGs, which show him in compensated respiratory acidosis, which we can see it's compensated because the pH is normal, the CO2 is high, and then the bicarb is high or in range depending on which scale you're looking at, but on the higher side. And this has been the trend the entire time that he's been in the hospital.
Here we have a healthy lung versus a lung with COPD, just so you can see how bad the damage gets. In a healthy lung, the bronchial tubes are clear and have no inflammation. The alveoli expand and collapse with each breath. Oxygen moves through the air sac walls and into the blood, and carbon dioxide moves into the air sacs to be exhaled. Now with COPD, you have bronchitis and emphysema, so it changes how your lung looks and how it functions. The alveoli lose their elasticity and shape, making it hard to exhale. Air gets trapped in the lungs. The bronchial tubes become inflamed and narrowed, and thick mucus forms, causing a chronic cough, which can sometimes be described as a smoker's cough.
Our medical diagnosis includes the definition of the medical diagnosis, the common causes, the incident rate in Texas, treatments, and medical interventions. So for the medical diagnosis of chronic obstructive pulmonary diseases, it is a group of lung diseases that blocks airflow and makes it difficult to breathe. This causes damage to the tiny air-filled sacs known as the alveoli. The damage done by COPD cannot be reversed. Common causes of COPD include smoking, your environment, and exposure to air pollution for a long amount of time. The incidence in Texas is about 1,109,000 people that have COPD. The treatments for COPD include oxygen therapy, bronchodilators, and inhaled steroids, along with combination inhalers. Medical interventions include chest x-rays, pulmonary function tests, and ABGs. For our medical diagnosis of COPD, our patient refuses to stop smoking and he frequently smokes while he's on oxygen. The oxygen actually exploded while he was smoking, and this brought him into the ER, which caused his hospitalization. We know that smoking causes vasoconstriction, and this decreases his oxygenation. When our patient arrived in the ER, he presented himself in tripod position in order to increase his oxygenation. We included this in the medical diagnosis because we wanted to include how his actions led to his hospitalization and increased his symptoms of COPD. Our nursing diagnosis includes the definition of the nursing diagnosis, interventions we implemented, medical orders, and medications the patient was receiving. This is our nursing diagnosis slide. We went ahead and decided to go with the nursing diagnosis of impaired gas exchange. As shown in the earlier slide, our patient has been diagnosed with the medical diagnosis of COPD, and we know that this disease includes the process of damaging the alveoli over time, which then decreases the surface area that oxygen is able to attach to the blood, and so therefore the whole body suffers from perfusion loss. Some of the major nursing interventions that we're going to be doing, now clearly for this patient he was sedated, but in a patient who is not sedated and who is AAO times 4, we will be doing some education points about incentive spirometer. We'll also talk to them about cessation of smoking. That's a major thing that this patient did not listen to in the past. We had in the documentation seen that nurses had attempted to
educate him on smoking and why it is progressing his disease so much, and he just refused and had no family support to help encourage him stop smoking. And we understand that it is a hard thing to do when you have no support and no one to help you out with it. So another point that we want to talk to him about is diet education. We want to talk to him about limiting liquids while he's eating food so that he's getting proper nutrition and not being filled up too quickly. And also we do not want risk of aspiration. And we want to talk to him about O2 therapy and what that looks like. And when we're in the hospital, specifically with this patient, we want to wean him off as effectively as we can. As you'll see in the conclusion, there was an attempt to wean him off his FiO2 settings and bring him down to try to get him off the vent, and he did not tolerate that well at all. He immediately desatted, and it was just not good. It was not a good scene, let me tell you. He was going downhill. Another nursing intervention that we do with almost all respiratory patients is incentive spirometer. We know that this helps with lung expansion, and lung expansion helps with better gas exchange. We're also going to be performing oral care every 2 hours to make sure that there's not any breakdown in the oral mucosa and making sure that we are not drying him out completely. We'll be doing frequent respiratory assessments throughout our shift to make sure that he's not declining, and all changes in status are being reported to the healthcare providers so that we can better care for this patient. We're also going to initiate DVT precautions because we understand that because he's immobile, he is at a greater risk for DVT, so we're going to implement SCDs. And lastly, we're going to make sure we're turning every 2 hours to help skin breakdown and avoid pressure ulcers. Some of the medical orders that were seen in his chart included pulmonary hygiene, ventilator settings as we talked about earlier, and also he was on tube feedings. You can see a list of his medications on the screen. These were just a series of things that included sedation, antibiotic therapy, and also insulin, and some PRN medication to give as needed.
In conclusion, our patient is in the declining stage of COPD. This is evidenced by his diagnosis of respiratory acidosis. His need for ventilation assistance is the labs indicating that his kidneys are declining, exhibited by a lack of perfusion. His behavior has shown a lack of interest in participating in his care, as evidence his refusal to stop smoking. He also doesn't have any familiar support to aid him in his care. The patient is also declining by a worsening O2 state. He has not been able to wean off his vent, and he has increasing symptoms with a poor prognosis. Attempts were made to lower his FiO2 with no success. Patient remains at 70% on his FiO2.